At midnight, your body stops making insulin. Soon, sugar rises in your bloodstream, while key muscles and fat tissue behave as if fuel is scarce. Then your liver starts turning fat into acidic ketones. This is the pathway toward diabetic ketoacidosis, a medical emergency that can dehydrate you, disturb electrolytes, and change how you breathe and think. Here are the rules. Your pancreatic beta cells suddenly stop releasing essentially all insulin, while your other organs begin healthy. Real type 1 diabetes usually develops over time. This instant switch-off is hypothetical. There is no universal countdown. Stored insulin, meals, hydration, illness, medicines, body size, and treatment change the speed. Normally, a meal raises blood glucose. Pancreatic beta cells sense that rise and release insulin. The hormone tells muscle and fat tissue to take up and store more glucose, while telling the liver to reduce its own output. Not every cell depends on insulin in the same way. The brain and red blood cells are important exceptions, but insulin coordinates the fuel system. At 12:01, that coordination begins disappearing. Insulin already circulating does not vanish instantly, so you do not collapse beside the bed. As the signal fades, muscle and fat take up less glucose, while the liver breaks down glycogen and makes new glucose. Blood sugar rises from both ends. Less is cleared, and more is released. Now the kidneys become an emergency spillway. When blood glucose climbs high enough, filtered glucose enters the urine. Water follows by osmosis, carrying electrolytes with it. You urinate more, perhaps waking repeatedly. Thirst becomes intense. Your mouth dries, your pulse may accelerate, and body weight can fall. Not from healthy fat loss, but because water is leaving fast. Here is the fuel paradox. Your bloodstream may be packed with glucose, yet important tissues are losing the insulin signal that helps them use and store it efficiently. Stress hormones push the system toward a fasting state. You feel exhausted and hungry while the glucose meter climbs. Meanwhile, the liver keeps releasing fuel because the hormonal message says the body is running short. Then fat tissue opens its reserves. Fatty acids stream to the liver and become ketone bodies, especially beta-hydroxybutyrate and acetoacetate. Small amounts of ketones can be normal during fasting. The dangerous difference is that insulin, the main brake on uncontrolled fat breakdown and ketone production, is almost absent. Production can outrun the body's ability to use and remove them. Ketones are acids. Bicarbonate begins buffering them, but that reserve falls as ketones accumulate. The blood becomes more acidic. Nausea, abdominal pain, and vomiting may appear. Breathing turns deep and rapid as the lungs lower carbon dioxide and raise pH. This is Kussmaul breathing. Acetone can make the breath smell fruity. The lungs are compensating, not curing the cause. The electrolyte picture is tricky. Urine and vomiting can drain potassium from a body. Yet the first blood test may show normal or high potassium because insulin deficiency and acidosis shift potassium out of cells. The bloodstream can look potassium-rich while the body is depleted. That contradiction matters. Both the crisis and its treatment can destabilize muscles and heart rhythm. As dehydration deepens, circulation weakens, and the kidneys filter less. Glucose and ketones become harder to clear, creating a feedback loop. Thinking grows foggy. Drowsiness and confusion may follow. Severe untreated DKA can progress to collapse, coma, and death. But an exact death clock would be dishonest. In adults, symptoms may build over hours to a few days with wide variation. In real life, doctors also ask why insulin disappeared. It may be the first presentation of type 1 diabetes. Someone using insulin may have missed doses, or an infusion pump may have failed. Infection, heart attack, stroke, surgery, or another major stress can sharply increase insulin needs. Finding the trigger helps stop the crisis from returning. In the emergency department, DKA is not diagnosed from one glucose number. The team checks beta-hydroxybutyrate, blood glucose, venous pH, bicarbonate, sodium, potassium, kidney function, and other electrolytes. An ECG watches the heart. The examination looks for dehydration and altered mental state while tests search for a trigger. Ketones plus metabolic acidosis are central to the diagnosis. Treatment starts with carefully selected intravenous fluid to restore circulation and replace losses. Then insulin stops new ketone production, reduces the liver's glucose output, and helps glucose and potassium move into cells. Measurements repeat frequently because the chemistry is changing. This is controlled correction, not a race to force one number down as quickly as possible. Potassium makes rescue a balancing act. As insulin and fluids work, blood potassium can fall rapidly. If it is already too low, clinicians may replace potassium before insulin, because pushing more into cells could trigger a dangerous rhythm or weakness. Later, glucose may be added to the force so insulin can continue clearing ketones safely. The crisis ends when acidosis and ketones resolve, not merely when glucose looks better. After recovery, the hypothetical switch remains off. Without beta cell insulin, the body needs replacement insulin every day through injections, a pump, or an automated delivery system. Monitoring glucose and ketones, keeping backup supplies, and following sick day instructions help prevent another DKA episode. Transplantation can restore insulin production in selected cases, but routine survival depends on reliable insulin replacement. So what happens if your body stops making insulin overnight? The danger is not simply too much sugar. The entire fuel control network flips direction. The liver releases glucose, fat breakdown accelerates, acidic ketones rise, and water and electrolytes leave through urine. Insulin is more than a glucose key. It is the signal that keeps the body from treating abundance like starvation.